My name is Ajay Kand. I am now working in the South Asia region of the World Bank, but also a little bit in the East Asia and Pacific region of the World Bank. And if you see me moving to the corners of the room, it's not because I'm trying to hide from you, I'm trying to hide from that light coming into my eyes. So just FYI. So as Nadeem said, this is the first of hopefully several sessions on health financing that we will cover during this week. So basically this is sort of an introduction to the framework, and the way I have set it up is we're going to do a very, very quick review of the basics of universal health coverage. I know that you discussed the definition yesterday, but we're going to look at it from really the health financing angle. Then talk a little bit about the health financing control knob. You heard about the overall framework of using control knob. Here, basically, we'll hone in on one of the specific control knobs. We'll take a tour of the world, looking at the global health financing landscape, how and how much are resources mobilized, and how are risks pooled across countries. And finally, we'll have sort of more of a discussion session where we look at different health financing modality and look at the pros and cons of different options for resource mobilization and risk pooling. And hopefully that will also set a stage for the second part of the lecture, which I'm honored to be in front of Abdo here, who will focus more on one of the specific modalities, that of social health insurance. So let's just get started. Let's begin with a basic, very quick review of universal health coverage. I'm just putting the definition up there. This is WHO's definition of universal health coverage. Universal health coverage is about ensuring that all people can use the promotive, preventive, curative, rehabilitative, and palliative health services they need of sufficient quality to be effective, while also ensuring the use of these services does not expose the user to financial hardship. It's quite a mouthful of a definition. In fact, this definition is from WHO. The whole concept of universal health coverage was redefined a couple of years ago. And I think the basic reason for doing this was that there was a perception that universal health coverage was really about curative care. And so the WHO made it a point to say that it's not just about curative care, it's also about promotive, preventive, and a whole list of things. And I think the second part does not expose the user to financial hardship is something I want you to keep in mind for the rest of the lecture and for all the financing lectures that we do. So I'm going to look for a volunteer to quickly do a review of what you saw this cube yesterday, right? So can I get a volunteer to explain to your other colleagues what is this cube representing? It's one way to represent universal health coverage, making progress towards universal health coverage. So what is this cube representing? This is sort of a stylized, simple version of the UHC cube. Who wants to volunteer? Otherwise, I'll volunteer somebody. Anybody want to take a crack? And I think you have to use the microphone, right? So who wants to do a refresher on what is universal health coverage when it's conceptualized this way?
Yesterday we've been asked if we like this cube, so I do like it. So it reflects the situation. Yeah, it a bit contradicts to the term universal health coverage, which means that we provide everybody with everything. But in reality, this cube defines that we cover what kind of population we cover, because we can select either we cover children or some other population. So which service?
This is really the population that's being covered, right?
Yeah. So either we cover poor or rich or blonde or whatever.
Okay.
The other is services, which services are covered. So we can cover everything, or we should focus on most important for the current situation in healthcare landscape procedures. And also we can consider the cost of the, we cannot forget about cost, because we have this envelope. It's the amount of money is always not enough, so we should understand which price we are ready to pay for the services.
Does everybody agree with this conceptualization? Anybody has any additions or corrections or edits?
So regarding the cost sharing.
I just need to bring the mic 1 second.
Regarding the cost sharing and fees, it's related to what services are, so the percentage of payment which should be paid directly from the pocket of the patient in the point of delivery of the services, for instance. So this also is one of the important dimensions of the universal cost coverage.
That is correct. So it's not just the cost of services, it's the proportion of costs that you're having to pay directly out of pocket at the time and place of seeking care.
Yeah.
So where is, go ahead.
Just that, looking at the cube, I'm also looking at the cube from another angle. If you look at the population, not everybody is covered.
Right.
Services, not all the services are
In
covered.
this particular example.
Yes,
Yeah.
and again for the costs, not all costs are covered.
Right.
So the conceptualization of here is that it is a journey.
It is a
A
journey.
journey.
Yes, it's a progression. So as you're trying to move towards universal health coverage, you're trying to cover more and more people with more and more services, having to pay less and less at the point and place of seeking care out of pocket, right? So where is health financing in all of this? I know you did different iterations of the cube earlier yesterday. You did also that, this is just a simplified version. You had multiple schemes and things like that. But let's stick with this particular example. Where is health financing in all of this? Where is financing coming in? If somebody can help with the mic, Nadine. So where is health financing in all of this?
Vertical line,
The what?
direct cost.
The vertical line. Is that the only place? Where else is financing?
Services covered.
Services covered? Yes, yes. I can see what
You know,
that.
three-dimensional financing.
Yeah. What's the entire cube representing?
This is financial.
So what is the entire cube representing? The entire cube is actually representing total health spending in an economy. And what is this blue part representing?
It's covered
Covered how?
by public fund, by health insurance funds, by
So that is where health financing comes in. I would use the term prepaid pooled health spending. So basically the conceptualization of universal health coverage, health financing is intrinsic to the whole definition of universal health coverage. It means you want to have more people covered with more services and having to pay less out of pocket directly at the time and point of seeking care with prepaid pooled funds. And the entire cube represents really the volume of health spending in a country. And we'll come back to this a little bit more, but I'm just trying to make the entry to health financing specifically. And you must have covered this yesterday. Usually this is called depth and scope of coverage. And I think this is breadth, this is scope, and this is depth of coverage. You usually see this terminology being used. And I think another important point to remember is what the UHC cube misses. And I think you had a little bit of a discussion on that. I'm just flagging it because it's important for discussion on health financing. There's nothing related to the quality or efficiency of healthcare here. There's nothing about foregone care due to costs and other factors. So, if you don't seek care because you're too poor or you don't have access to services, you don't spend any resources, that's not captured in this cube. This cube captures all services for which there has been some spending. And also it doesn't capture indirect costs. Indirect costs are if you're sick, you may lose income, or you may have to forego or you may have to wait excessively to seek services. So those sort of things are not directly captured. But let's go back to this. So what is prepaid pooled health spending? And when I used to teach this earlier, I had this very complicated definition, but I think it's better if you explain to me what is prepaid pooled health spending. So I'm going to show two graphics, and I'm going to have you think about them and respond to what you see. So what are we seeing over here in this simple graphic analysis. Don't look ahead. Yeah. All right, so what's happening on the left-hand side, for instance? What's that representing? Sorry? I think maybe we need a mic.
Contributors.
Who wants to talk? We can use the mic. People want to say.
That's one.
Here you go.
The picture on the left depicts the population.
Okay.
And this population in the box are those who are already covered by insurance, in terms of prepaid.
Great.
But out of all
What
this,
makes you think they're covered by insurance?
because I was smiling.
Oh, good.
Whereas on the right, it is out of this population that one of them is sick.
Okay.
Not all of them will be sick. Only one or few are sick.
Okay.
And then the amount of money that has been pulled together for everybody will now present for this person to go and access healthcare. Therefore, they will be at a lower cost.
Close enough. This is the entire population, not necessarily those who are covered. A proportion of, in this case, one person gets sick, and I think this is meant to denote that they're paying out of pocket when they seek care. What's happening in the second case? Sorry, I'll move out.
The person is not afford.
So if you can raise your hand.
The second, it shows that the person can't afford to cover the cost of the treatment or service.
Why do you say can't afford?
Because, well,
I mean, you see different things like art, right? When you go to a museum, you see different things. Let's keep it very simple. There's no complication here. So what's happening in the second scenario? Think of this as a...
he can't afford by him directly, and the money should be covered by pooling fund, by common fund which is created by
Yeah. So just to clarify, the size of this is the same. So it's the same, roughly the same amount of money. So just so you don't get confused. So if you can repeat what's happening in the second scenario.
The second scenario is that the person is covered by, so he can't pay directly from his own sources, and is covered by sources from the pooling fund.
Okay, so where is the prepayment here? So what's representing the prepayment?
So the second one is related to prepayment, because the money who is in which is in pooling fund,
Yeah.
is from prepaid contributions.
So basically what's happening here is everybody here is prepaying a small amount that gets pooled, and then out of that pool, the financing happens. So this is what is representing prepaid pooled source of financing. And there are one or two things that are very important that need to occur for this to hold. So under what conditions will this system of prepayment and pooling hold? Again, don't think of insurance, don't think of complicated things. Just this is a stylized population, somebody's gotten sick, instead of paying out of pocket, you're getting payment out of prepaid pooled funds. So what are a couple of things that have to happen for this to work, for this system to work?
People have to volunteer, contribute.
That's a very nice way to put it. Would you say people have to volunteer? People have to agree to prepay. In fact, quite the opposite. You may have to force people. You may have to make it compulsory for them to prepay these sources. One other very important...
Everyone can't get terribly sick at the same time.
Exactly. Yes. Everybody cannot get sick at the same time. Otherwise, what happens? The whole system collapses. So this is what we are pooling is not just funds. You're pooling risk, right? It's not just pooling funds, and the system only works if you don't have an Ebola outbreak that affects everybody. There's no difference between an out-of-pocket system and a prepaid pooling system if everybody gets sick at the same time and has to utilize care. And for those who are interested, and we can talk about this a little bit later, there are some linkages to how banking systems are set up. So in a banking system also, you're counting on the fact that not everybody withdraws funds at the same time, and so there's some logical. Go ahead.
Sorry for interrupting. I just wanted to share a comment because someone said in the front that people should volunteer. So what's interesting, in Lebanon a while ago, we wanted to have, so we have the Social Security Fund for the population working in the formal sector. So a lot of the, which is around 30%, so a lot of the population is not part of the Social Security Fund. So to actually try and fix the issue, someone thought that maybe we should do a voluntary insurance scheme, okay? So people would volunteer with the government, with like a public fund, and they would go and they would pay premiums, and then they would get covered. So what happened is, which is very logical, only the sick went to the voluntary scheme.
Yeah.
Only the sick and the elderly, and the voluntary scheme went bankrupt in a couple of years because everyone was getting sick at the same time. So in risk pooling, voluntary isn't always a good idea.
That's the whole logic behind pooling of risks. So you need the healthy people to also prepay, otherwise the system will not work. Any other questions or comments? Yeah.
I'm afraid that this graph does not show the reality because it's probably 1 out of 60 people who is seeking health care. But taking the example from Kyrgyzstan, we have 1 million hospitalizations out of a population of 6 million, not to talk about the ambulatory care. So the relationship is very much different in reality.
So this is related to the point that you need to have enough people who are healthy and not utilizing for the system to work. Otherwise, it becomes closer and closer to really an out-of-pocket finance system.
Ajay, how do you decide how many is enough?
Are you allowed to ask questions?
Mine was always I can ask, they don't always have to be answered.
I think my question is actually related to the Mind Health episode, which is that, so we understand that you not only do you pool resources, but you also pool risks. So what do we need to do to mitigate the risks so that at any given point we have enough healthy people that can balance the unhealthy people?
In fact, that is one of the key questions in order to set up such a system, is that you need to have enough healthy people, and actually there are statistical models and actuarial models that are used to decide the size of the population that needs to be there, the risks, the age profile, and so on and so forth. So though that is actually a very important question, and it's part of the debate that's happening right now in the US for Obamacare, making it compulsory for people to join these sort of prepaid pool funds, which in the US is insurance. Was there another question? One more question or comment?
I'll be interested to know how encouragement of prevention.
Yes, we'll come to that a little bit later. This is basically, you may have an incentive if you're the agency that's pooling the funds. In order to prevent utilization, you have an incentive to try and save money here by trying to prevent as many people from falling sick as possible. So, that's sort of a built-in incentive over here. Otherwise, your premium rates or prepayment will go up. Yes?
How do you define what the pool is?
So the pool is also defined by the risk profile of people. So I have another slide a little bit later. So you actually need to have a distribution in the population of the healthy and sick. Age is a key determinant, so you need to also have the young and the old. But there's also one other thing that can happen with the prepaid pool system. Think of equity. So what else enables an equity thing to happen here? How is this system facilitated for equity? Just how rich and poor people? So you can have rich and poor people in the population. And how, if you're a policymaker, would you bring in the equity dimension? If you see the mic there.
So probably contribution of each member should be related to real income of each individual.
Yes.
And in this case, will be much richer, will pay virtually for people who struggle with money, so
yes.
for poor.
So that's another thing in the system, is that you can adjust the prepayment rates to allow for some equity-related adjustments. In fact, there's a very famous philosopher, if you see who says, compulsion and subsidization are necessary for universal health coverage to continue. So I'll move on from here, but just to remember that you need to have the healthy prepay, and then there are mechanisms by which you can subsidize the prepayment for those who may not be able to prepay. And sort of to summarize this, usually this is what people call, there are some things about a health shock, that is when you fall ill, that makes it facilitative for financing from prepaid pool sources. The 4 U's, health shocks are unwanted and undesirable. So normally, unless you're a hypochondriac, you're not choosing to fall sick and check yourself into a hospital. So it's you're consuming a service that is generally not wanted. They're largely uncertain and unpredictable at the individual level. So normally you don't quite know when it is that you're going to fall sick, right? So that's, however, statistically, even if at the individual level, this is unpredictable, there's a law of large numbers that say that at the aggregate level, this projected expenditures become more and more predictable as more and more people get into the pool. The third U is what we discussed, that health shocks are uncommon. Not everybody has to fall sick at the same time. And then, it's the health shock is not just a health shock. You also have a financial shock. So when you fall ill, there's also a financial shock. And I think that recognition, that when you fall ill, it's also a financing shock, is what makes universal health coverage, the whole definition of universal health coverage, very important to consider. It differs from previous sort of health for all initiatives and things like that, really putting the health financing angle front and center. So this is an example from India, just again reiterating the point that I think he was talking about Kyrgyz Republic. So here's an example from India. This is from the latest National Statistical Survey. It's just showing you that, if you look at the bottom row, about 10% of the population in India reported that they were ill in the past 15 days. Inpatient utilization in the past year was about 3.7%. Outpatient utilization was about 8.4%. This is quite typical for developing countries. I think the numbers tend to be a little bit higher in higher income countries. I think inpatient utilization rates in OECD countries and so on is actually higher, right? Maybe more like 10%. So that can matter in terms of setting up how you will finance your system from prepaid pool sources. And here's another way to look at this. So this is basically showing you, on the x-axis, it's showing you the ranking of households in India based on how much they spent out of pocket. So basically the first bar here is telling you that the top 1% of health spenders in India spent about a quarter of all health spending out of pocket in that country in that year. And then as this is only out of pocket, but the logic remains that you have this skewed distribution, but there are some people in the country, so the bottom 50% had no health spending whatsoever. And again, this is thinking about how does this prepayment pooling work. It works because not everybody is getting sick and utilizing, so there's a skewness in the distribution of health spending in the population. This is very typical. This is true even for the US. You'll see that the top 1% accounts. This is top 1% of health spenders, not top 1% of economic status. Yeah, so this is just showing you that there's a. So what do you need for prepayment pooling to work? You need to have these people also prepay a small amount to be able to cover these people. So that logic has to be kept in mind when thinking about health financing. And just to summarize, it really, as we've already talked about, prepayment pooling works because there's an intrinsic pooling of risks. There's intrinsic cross-subsidy from low-risk to high-risk individuals in terms of health. There's also an equity subsidy. If you can make people who are poorer prepay less amounts. And also in some cases, you're also doing a cross-subsidy over time, age. So as you're younger, you will prepay. As you're getting older, you will withdraw from the system. In fact, that's the basis of the American system, Medicare, where you pay when you're below 65, then you stop paying after 65, right? And then you get benefits after that. So there's also you pay a smaller bit. So this is sort of intrinsic to the whole notion of prepayment and pooling. And I just want to, this is sort of a lot of words, but this is really putting down, these are notes for you of what we just talked about. Pooling refers to the collection and management of risks. The logic is that an individual would want to prepay a small amount so as to avoid facing a financial shock when they get sick. And pooling also ensures the predictability. I think this slide is behind, but predictability of aggregate health expenditure. Prepayment gives you options to finance these risks more equitably and efficiently. So again, we've really talked in very generic terms. And also I want to define a few terms. Some of these have already been discussed that you may come across in your health financing sessions remainder of the week. There's this term called adverse selection. I think this was already discussed. Somebody already explained what is adverse selection. So can you just repeat, what is adverse selection?
Adverse selection is when they sick people with pool rather than healthy people.
So adverse selection is that if you don't make prepayment compulsory, I think that's if you don't make prepayment compulsory, you end up encouraging people who are sick to join the pool. So the whole benefit of prepayment pooling doesn't work. And Abdo will talk a little bit more about that. So this is a sort of economics term that you'll often hear. The other one is called moral hazard. Has anybody heard of this before? What is moral hazard? It's not what it sounds like. Go ahead.
Moral hazard is using resources without the intention of having a need for that.
It's a problem of overutilization. When you don't have to pay out of pocket, you're using prepaid pool funds, you may have a tendency to overutilize because you're not having to pay at that immediate point. Your costs are deferred in some ways and shared by others. You will also hear of the principal agent problem. Have you heard about this term? Does anybody want to? Again, you'll have this in your notes. These are sort of technical terms that you may hear being used later. Go ahead. The principal agent problem?
It's that there's unequal information between the provider and the patient. So the patient may not know what they need and they only find out at the point of getting.
So there's an information asymmetry that creates some sort of problems in terms of when there's a transaction, the doctor may know much more. Also, you may know much more about your health condition. And so, the insurer may not know. So there's these problems in the system that can create issues and challenges. And finally, risk amenability is really that whole point that you want to have insurance, some sort of insurance. And I'm meaning insurance here in the economic term, not insurance as a firm insuring you. But insurance, you have to have shocks that are amenable to insurance. So not everybody has to get sick at the same time. It's unpredictable. So you do, as an individual, want to prepay to avoid the financial shock. You may not be able to avoid the health shock, but at least you can try to avoid the financial shock. So this is sort of, I'll just keep moving. UHC is a sustainable development goal now. Unlike the Millennium Development Goals, it's now included as one of the SDGs. It's under SDG 3. And there are sort of two, there's a target on achieving universal health coverage, and there are two sets of indicators that are recommended to measure progress towards universal health coverage. You have a session on monitoring and universal health coverage later. I think it's on the final day, so I won't go too much into detail, except to point out that WHO and World Bank have recommended some tracer indicators to measure progress towards universal health coverage. A lot of them are preventive, promotive, and curative indicators, but I'm going to just make you focus attention on the financial protection indicators that are included. Again, here you're trying to assess to what extent are people paying at the time and place of seeking care out of pocket. And really the indicators have to do with the percentage of households whose out-of-pocket health spending exceeds either 10% or 25% of their total consumption expenditure, because numbers above that are indicative of having catastrophic spending. What is called is catastrophic from a financial point of view, not from a health point of view. So if you're poor and have the flu and have to pay out of pocket, even that can be catastrophic from a financing point of view. And also the percentage of households who are pushed below the poverty line. Let me try to explain this. This is basically showing the distribution of households in an economy, increasing in terms of their wealth. This is the poverty line. So if you're a household here, below the poverty line, and face a health shock and have to pay out of pocket, you're pushed deeper into poverty. If you're just above the poverty line, you're pushed below the poverty line. If you're a household here, again, you're being pushed below the poverty line. If you're a household here, you are not being pushed below the poverty line, but again, you're facing a relatively large share of expenditure that's more than 10 to 25% of total consumption. So this is sort of the logic behind that measurement of financial protection.
I just had a question, which is probably just academic, but is there consensus now on what proportion constitute as catastrophic health expenditure? When would you use 10 versus 25%, or even another?
How many hours do you have? So they kept fighting and fighting and fighting, but the SDGs have a consensus. The UN has a consensus, but of course within different countries you may want to pick different thresholds. So the SDGs have said to do both 10 and 25%. So both are reported. And earlier on, WHO had a different one, 40% of non-food expenditure and so on and so forth. So the latest iteration is 10 and 25 both together. For some strange reason, they have dropped the impoverishing part, even though I think from a financing point of view and a Ministry of Finance point of view, the impoverishing part is important, but that doesn't mean you can still measure it at the country level if you want to, and if you think that's something that's going to be useful to track. So, but that's not the one that they have included in the SDG monitoring framework. But again, you'll talk a little bit more about this later when you're talking about monitoring universal health coverage.
Does the World Bank have a level?
This includes the World Bank. This is WHO and World Bank.
But does the World Bank have an agreed upon level that's used
10 to
consistently?
10 to 25%.
10 to 25.
Yes, both 10% and 25%. So usually you'll end up having very few households that spend more than 25%, and a sort of a larger number that spends more than 10%. The key point is also track it over time, whether or not it's going down. The thing that you have to keep in mind when you're looking at financial protection indicators is that you can have households that are foregoing care. So there's something called the zero inflation problem. So you have lots of zeros in your data. That means zero health spending, out-of-pocket health spending. So it's not. So some of that zero is because you're healthy and don't need to seek care. But then you, especially if you're in a low-income country, a low-middle-income country, there are some zeros because you needed care but couldn't afford it. So so just keep in mind, in isolation, you don't want to only look at financial protection. You also want to combine it with service coverage. So just some headline from the latest UNC monitoring report: at least half the world's population still lacks access to essential health services. About 100 million people fall into poverty. 200 million women lack adequate access to family planning services. This is online, and also the logic and the measurement framework is online, and this is tracked every year. Now, briefly, we've already talked a lot about health financing. Let's just talk about the health financing control knob and really come back to the framework. I think this was introduced yesterday in terms of having control knobs and conceptualizing the health system. We're going to focus really on the first knob, and as Nadeem would say, the most important knob, on financing. In this framework, payment and financing are separated, but in some frameworks you'll see the two of them integrated. Sometimes you'll see payment as being part of health financing as well. And of course you have organization, regulation, and behavior. And basically the point to make here is that sort of the traditional narrow concept of what constitutes health financing is this. Normally when people think of health financing, they think health financing is really about raising resources for health, right? Is that all that health financing is about? Is that it's really about how much money you have for health, based on the discussion we've had?
Thanks. So the reason is how you're using them afterwards, like the distribution of money. What do you think for? What do you provide for them?
So it's not just the quantum of financing that is there, it's also how it's raised, how it's prepaid, how it's pooled, and how it's utilized. So when we talk about health financing, we are talking not only about how much money is raised, but also how it is raised. We're talking about how the money that's raised in the health system, the risk is pooled, and also about how those resources are allocated, primary care versus hospital, so on and so forth, and also how providers are paid using the money. So health financing is not just about how much money is there in the system, it's about pooling, purchasing, broader concept. And ideally, this is just sort of the sort of formal definition, it's concerned with mobilization, accumulation, allocation, and utilization of financial resources in order to help countries make progress towards objectives such as universal health coverage. Ideally, you want to have a system that raises sufficient and sustainable revenues in an efficient and equitable manner. Again, this is sort of how you want to have the objective to manage those revenues to pool health risks efficiently and equitably. You want to ideally have an explicit benefits package. This is the services that are commensurate with your revenues. So you don't want to be in a situation where you're claiming to finance much more than what you have prepaid pool financing for, and whether or not you have a service delivery capacity. So don't include neurosurgery in your benefits package if you don't have neurosurgeons. I've been to countries where that happens. And also you want to assure allocation of resources and purchasing of health services in both an equitable and efficient manner. The key point here to remember is, it's not just, you cannot just spend your way to universal health coverage. You can't just increase spending and hope to get universal health coverage. You're sitting in a country here in the US that spends a lot. And it's, yes, don't look ahead. But it's coming, yes. It is the most, one of the highest, yes. So, and in fact, it doesn't have universal health coverage. So, this is basically, these two things are sort of the introduction to some terminology, how health financing is intrinsic to how we conceptualize and define universal health coverage. What's the health financing control knob? What are sort of the levers that we talk about when we're looking at the health financing control knob? And really to understand that, what makes financing for health different from financing for agriculture or for education. It's really this whole thing about pooling and prepayment as an efficient mechanism to be able to have health spending. So let's, for the remainder of half an hour, 40 minutes, let's sort of take a tour of the world after having gone through these definitions and concepts and language. Let's just take a look at the global health financing landscape, just to get a sense of how much and how resources are being mobilized globally and how are risks pooled across countries. So basically, this is sort of I've always been accused of going too fast during these graphics. So let me just explain this a little bit more. So the x-axis is showing you the national income of a country, the gross national income per capita of a country. This is using the World Bank's classifications. If your national income is less than about roughly $1,000 per capita, you're classified as low income. If it's between $995 and about $4,000, you're lower middle income. If it's higher than that, you're upper middle income. And then over $12,000, you're classified as high income. And this is showing you on the y-axis health spending per capita in US dollars. So what do people see here? what are 3 or 4 things that stand out? If somebody shows you this sort of landscape of total health spending per capita in countries, across countries in a given year versus national income. And I've tried to pull out the countries that are in the room. If you don't see your data point there, it's because the data was not available in global databases. And also, please don't fight with me that it's not $38, $40. That's not the point here. Yeah. So what do you see over here? It's a very strong positive correlation between how much countries spend and their national income. What else? So as you become richer, you tend to spend more. What else might you see here? There's a huge, one thing that always strikes me, there's a massive, the point that you were making, massive difference between the low spending countries and the richest countries. So you have countries that spend $10,000 per capita per year. The US is one of those. Does anybody know the 2 other ones that are spending over 10,000?
Swiss?
It's Switzerland, yes. No, Japan is not that high, it's Norway. And then you have countries that are spending, this is about $18 per capita, and I believe that's Central African Republic and Mozambique. So there's a very huge difference in terms of if you think of that big stack, in terms of the resources for health across the world. And of course there's a strong positive correlation, but also something else you can check over here. So if you think of the red line as sort of saying this is what you might expect to be spending for your level of income, you can also get a sense of whether or not you're spending more or less than expected, right? So there's no, it's not an exact science. And you can see like countries like India, health spending is much lower than would be expected for India's economic status. Sort of a way to benchmark and get a sense of where you stand globally.
I have a question.
Ajay, just to clarify, this is total health expenditure?
Total health expenditure.
Private, everything?
Public, private, everything.
So this one was my question.
Yeah, this is total health spending.
Okay, sir, this was my question regarding the total.
Sorry for not clarifying, this is total right now, right? And then, of course, there are big differences also as a share of the economy, how much is health spending. The relationship tends to be a little bit less, this correlation tends to be a little bit less strong, but again, this is another sense you can get. Countries like India and Pakistan and Nigeria spend a relatively low amount of their resources on health, partly because the cost of inputs is low, but there's also foregone care, and there are many, many factors that can explain this. But this is sort of another way to benchmark where you are globally. The range tends to be, I think one of the lowest is about 2% of GDP.
Microphone died.
Your microphone is starting to...
My microphone?
Yeah.
Yeah.
It's probably
I think
battery.
it's gone out of battery.
How about this? Yeah, it's better. Let me change the battery.
So it goes from between 2% of GDP to almost 18% of GDP, and the country that spends about 18% of GDP is really the US. Sorry, I gave you too much. So,
You always do.
this is actually...
Use the mic.
What now? This is stopped working? Make sure you give me the right... So let's imagine what the next slide is going to be. Maybe you just have to...
There you go.
I just pressed the button.
Always. So here, basically, this is a slide actually that's borrowed from Abdo. It's showing one point to make it the global landscaping. That the health sector tends to be quite an important part of the economy. This is showing you for developing countries, the health sector's importance has been growing over time, and this is over 6% of GDP is total health spending, and public health spending is just about 3% of GDP. This is only for developing countries. This is not including high-income countries. And again, the point here to make is that The health sector share as an importance of the economy tends to increase. In high-income countries, it's actually more than 9% of GDP tends to be on health. And really, sometimes we have to remind ourselves that the health sector is really also a prominent source of employment, of revenues. In India, the pharmaceutical sector is very dynamic. You have medical equipment trade that contributes to the economy. You can have taxes on unhealthy products that are health-related that can contribute to revenues. So it's really that the country's health system is a growing and productive sector of the economy, and again, to make that linkage with the economy. Is it working? Okay. So I'm going to now summarize. We talked about really what was health financing in terms of how much and how resources are raised, how they're pooled, and how they're allocated. And really in this session we'll focus on the first two. And here's one simple way in which you characterize all these points. So this is sort of a health financing summary of a country. You try to see what are the sources of financing. They could be from the central government, they could be from provincial or state governments or district governments, could be from private firms, external financing, from households. This second part, it's called schemes. It used to be called agents. This is really how resources are pooled or not in a country's health financing system. So you could have pooling done by the Central Ministry of Health. So that brings me to the next question. Why is this considered to be pooling of funds? So if you can share with your colleagues and speak a little bit louder. So what's the prepayment and pooling here?
So this it's a general budget which is created from different revenues, different tax, different contribution which normally each citizen is obliged to pay, and this is pooling in governmental funds. So in different countries it's and different units or departments, Ministry of Finance or Ministry of...
So in a country when you have financing for health that's coming out of the government budget, what's the prepayment there? Taxes. And the pooling is done by Ministry of Finance that then allocates across the different sectors. So in effect, that's also a form of prepayment and pooling. So that's why this is important to keep in mind. Is there a question somewhere here? Yeah.
I don't think it's the role of ministry to pull into money. I think the role of ministry is politic maker. The role pulling money is responsibility of health insurance funds.
No. So the Ministry of Pooling of Risk, if you're having paying taxes are in effect a form of prepayment that goes into the Ministry of Finance's coffers. So in fact, there are many countries where there is no social health insurance. Anybody here who, in a country that doesn't have social health insurance or insurance? Yes? So you have, which are the prominent examples? The UK, right? Pooling is, prepayment is done through taxes. So it's a form of, in effect, pooling, prepayment by taxes and pooling at the government budget is in effect a form of prepayment and pooling. And of course, you also have other mechanisms, which we'll get into a little bit later, and Abdul will elaborate. A mechanism called social health insurance. I'll define it in a little bit. And you might have community insurance or NGOs. You might also have private insurance that pools. And then again, this is about how, the purchasing part. So how does the money go from here to providers? And how would you characterize out-of-pocket spending here? If you were summarizing a country's health financing system, how would you characterize where would be out-of-pocket spending? What is the source of financing for out-of-pocket? Can speak up a little bit? Private providers. Private providers. Now think again. I'm saying, what's the source of financing for out-of-pocket? It's households, right? What's the scheme? There's no scheme. So you're basically going from here to here. And I'm just going to show you an example. I'm picking out the example of a state of Tamil Nadu in India. It's because I'm currently working on this this week, and this is their summary of in the state of Tamil Nadu in India. It's a southern state. Its population is about 80 million. It's one way to characterize the health financing situation of a country. 5% of financing comes from the central government in the state, 16% from the state government, and so on and so forth. You see households, the largest source of financing, almost 70% of financing is out of pocket. You do have some small voluntary health insurance, some other schemes. This is sort of their tax financing national health insurance type scheme. This is not contributory. Basically, it's the government putting some of the taxes into a scheme that buys services from both public and private providers on behalf of the poor. So you often see these sorts of mechanisms. But we come back to defining some of these different concepts. And yes?
Thank you. I appreciate the Indian system, especially Tamil Nadu. It's a very large state which is equivalent to a country on its own compared to many, many countries around the world. And here I can see 5% coming from central government and 16% from the state government. How are you able to distinguish the funds coming from federal or the national government and the states?
So there are mechanisms by which you can tell, because for instance in this insurance scheme, which is a tax finance insurance scheme, the premium is say $10 per capita per family. $6 of that is coming from the central government directly. So the point you're making is sometimes you may have transfers from ministries of finance down to the state government that then allocates. Then you have to, in that case, you may not have a precise amount because that gets allocated across different sectors. Yes. So, and part of the challenge of trying to summarize the health financing system is to better understand. Are you from Nigeria? Yes. Yeah, so you have a very similar situation where you may not be able to clearly demarcate a direct line. You'll have a pooling that happens from here to here, and then that gets. So this is really the MOF, not the health, and then that gets. So there's a choice here being made, perhaps. In India's case, there are some earmarked funds that go to health from the central government. So basically, to introduce you to the different health financing modalities, we've already talked about some of these, but basically there are sort of 6 big buckets in terms of thinking about health financing modalities. These are modalities where revenues are raised in a certain way, prepayment pooling is done in a certain way, and often even purchasing is done in a certain way. So we won't focus on the purchasing function, and we just basically go through each of these to better understand when we say general government revenue financing, what do we mean? When we say social health insurance, what do we mean? And so on and so forth. Basically, let's start with out-of-pocket. That's really the easiest to understand. It's really financing by direct out-of-pocket payments made by users at the point and time of contact with public and or private providers. There is absolutely no pooling of risk, as we discussed, when you're paying out-of-pocket. Often providers are paid fee for service in out-of-pocket systems. And so this is sort of one characterization. Go ahead. Yeah.
So you said absolutely no pooling?
There's no pooling in an out-of-pocket
What about at the family level? Extended family pooling?
So there's no prepayment and pooling. You're still paying out of pocket. I thought you were going to ask me something more complex. There is one form of out-of-pocket payment which does have pooling over time. Does anybody know what that is?
Singapore.
Yes, Singapore, but also Obamacare has that, right? So you have these health savings accounts. They are a form of pooling over time where you're prepaying a small amount every month or every year and then tap into that to pay for any out-of-pocket expenses. Singapore is another example of that, but some other countries have been experimenting.
So that's on the individual level?
It's pooling at you can think of it as pooling at the individual level or at the family level, as he was pointing out.
So you save a portion of your income to the age of 65?
You save a portion of the income, and then you're able to dip into that and pay for services from that. You're basically saving for a bad day.
Like a bank saving account.
Like a bank saving account. But in some countries, it's mandatory to have that. Right? Even in China, I think in some earlier iterations, it was mandatory. Yeah.
It looks like a pension scheme. Or what happens if a person accumulates some amount on his or her account, and he doesn't need it, and will never ever need it.
Usually you're able to take that out. It normally is the case that doesn't happen, especially if it's for a lifetime course, but yes, it could happen that you don't ever need it. You'll be very fortunate never to need it, but of course this is not the best way of pooling. It's just one mechanism by which you can also pool. This is a savings account, and I think you're making my point. The second sort of health financing modality that we see across countries is community-based insurance. And is there anybody here from Ethiopia or Rwanda? Do you want to share with your colleagues what is this health financing modality? The community-based health insurance? I guess it's written on the right. But
actually, the community health insurance started like 4 or 5 years ago. So it's basically for the informal sectors, especially for the farmers. So the premium is very low. It's like $20.
So the farmers are required to prepay?
Yes.
A certain, is it a requirement or is it voluntary?
Actually, it's voluntary. It's entirely voluntary, and yeah, the premium is very low.
Premium is very low, and then who pools it? It's pooled at the community level.
At district level.
At the district level, and that pool is then used to provide a fairly shallow benefits package from.
In fact, the benefit package is very generous.
Oh, it is very generous.
Yeah.
Okay, on paper or in reality?
Even in reality. Yes.
Okay, good.
Yeah. And we are also thinking of like basically that to the sub-regional level, zone level, and the regional level. So we are working on that.
Yes, so some countries, initially when they begin to move towards prepayment and pooling, will do community-based pooling and prepayment. Community could be a district, could be even a smaller level, and this is basically to try and encourage people to begin to prepay so that they're protected from too much financial shock when they fall ill. Yes?
Can I ask a question?
Yes?
Usually this community-based health insurance, what type of services do they offer?
What type of services do they offer in Ethiopia? Is it all outpatient, inpatient?
All services. All outpatient, inpatient service. And except some of the services that they don't offer is like renal transplant, dialysis,
So
or
excluding high-end tertiary cares?
Yes.
That's
And
that
for
many
eyeglasses
not
and the like very small type of services are not covered by the health. That's why I say it's very general. So even neurosurgery is covered by this.
So the third sort of big health financing modality is voluntary private insurance. As here, basically you have private insurance companies. Your prepayment is basically your premium payment. It's voluntary, it's not compulsory. Your pooling is done by either for and or non-profit private insurance organization, and of course you may have different ways in which these insurance companies will pay providers. External financing, don't need to spend too much time on this. Really, this is financing from donors, Ravis, Overfund. External financing can be an important source of financing for many low-income countries. And one of the challenges that many countries face is then how do you transition from a dependence on external financing, and that's going to be one of the sessions later in the week. And then you're going to talk in the afternoon about social health insurance. I'm going to skip this because Abdo will talk in detail on this, so that's why there's no arrow over there, to really understand better what is social health insurance. Or actually there isn't. So, sorry, this is government, general government revenues. I've left social health insurance for the next. So this is really looking at the government budget as a source of financing for the health sector. So this is really what we talked about in terms of Ministry of Finance, taking taxes and then purchasing or providing services. You may have different taxes in different countries, of income tax, payroll, property taxes, could have consumption tax, VAT, excise tax. Usually the pooling is done at the government budget level in such a system, and then purchasing normally by line item budgets. So this is where the government will also provide health services. Almost all countries tend to have some form of general government revenue financing. And then social health insurance, I'm going to not go into too much detail here, but basically it's a compulsory form of prepayment, wage-based prepayment of healthcare that is then pooled by either a quasi-public or a public agency that then purchases health services, typically from both public and private providers. Yes.
At the risk of taking it backwards or forward, the issue of external sources. Now, we all know that using donor funds is never sustainable. Using donor funds for external sources, as you put it here, is never ever sustainable. But why are we still putting it in the books? You know, as a source. Why should we encourage it? Because we all know, and this is from international organizations to poorer countries.
Good point. So this is not a normative. This is not saying these are what should be the sources of financing. This is landscaping of how countries are financing. So yes, there are issues with sustainability. There are also issues with skewing priorities based on donors. So we'll come to that in terms of when we have a discussion on the pros and cons of different sources. Just wanted to show, for those of you who are not from social health insurance countries, this is a payroll stub from the Philippines. This is PhilHealth, which is their scheme that pools. So you have a dedicated earmarked payroll tax that goes to PhilHealth in the Philippines. Similarly, for Indonesia, their insurance agency, pooling agency is BPJS Kesehatan. That's sort of just to show this is an earmarked wage-based payroll tax that then finances healthcare. So let's. Instead of having a discussion, maybe we can just have a 5-minute question and answer to talk about what are the primary sources of health financing in your country. Have the primary sources of health financing changed in the country in recent years, or have they been fairly stable? If changed, what were previously dominant sources of financing in your country, and how do you think sources of health financing change as countries become richer? Perhaps a couple of volunteers to share what they know about how, we talked about how much, right? We saw that graph about how much you're spending. Now we're focusing on how that spending is financed. So who wants to volunteer? So what is the primary source of health financing in your country? Which country are you from? Moldova. Moldova.
So partially I provided such information in the previous session, but I will repeat, sorry for some repeating issues.
Moldova, the primary source of health financing is?
So the primary source of health financing are the contribution to the health insurance fund from employer and employee. Also, it's a big share, it's about 50% of pooling fund.
Social health insurance.
No, everything is social health insurance, it's mandatory health insurance, and it's only one pooling fund, which is administrated by the government. And the source of this pooling fund, I said it's premium paid by employee and employer. Other source, it's state budget to certain number of people. We have 16 group of people who benefit from government subsidies.
So those are the two big sources of
yes, in the same pooling fund, and the third one is self insurance. So it's
self-insurance.
Yes, so paid by individuals. Not that it's obligatory, but it's paid by individuals, which again is pulling in this single pooling fund.
Okay. That's, anybody else want to share what are the primary sources of health financing in your country? Yes, please. Can I just take your let me just get them first.
In Nigeria, we have different sources. One from the central government allocating money to health.
Central government?
Allocating money to health.
Okay.
Again,
Central health?
Yeah, central. Again, we have also, we call it national government.
So in our language, we call that general government revenue financing.
Exactly. Then we also have states allocating money mainly to finance insurance in the formal health sector.
So would you say that's the primary source of health financing in Nigeria?
In Nigeria, it's from the central government.
That's the primary source.
That's the primary source.
Okay,
then
we have to fight with WHO in the next slide.
Okay. There are also other sources, such as the social health insurance, where the formal sector is covered. So they remove a particular amount of money from formal health workers to finance that.
Please listen to your colleagues.
Again, we also have the community-based health insurance, which are in some communities, not general.
So in your sense, what's the largest source of financing for health?
From central government.
Largest. Okay.
Yes.
Anybody else? Maybe one or two others? You're saying no?
Audrey, there was somebody here. I already gave her the mic.
No. Oh, she wants it. Okay, sorry. Yeah, we'll come back to the one look ahead.
Okay, so I want the largest.
Which country?
Lebanon. So we have an insurance scheme that I talked about before, a social health insurance scheme. It only covers 30% of the population. So really effectively on the ground, 50% of our population, I'm talking about the Lebanese, are not covered by any scheme. And these are usually for inpatient care covered by the Ministry of Health through the general government.
So social health insurance for about 30% and general government revenue financing for the poor and vulnerable.
Exactly.
Okay.
And the uninsured, who are not necessarily poor.
And no out of pocket, of course, right?
Of course we have out of pocket. 37% is the current out of pocket.
How much is it again?
37%. Okay, and finally we also have a lot of refugees, and usually this is based on donor funding.
Okay, so maybe one last one before we move on and end with a set of discussion issues. One you pick, Abdul.
I don't know. Well, she's here.
In Albania, we have 28% from social insurance, and 72 are from government budget.
72% of the
Yes.
government budget.
Yes.
Okay, I'm going to show you the sources of health financing in your countries. I think you may need a microscope to look at it. We can discuss this later, but this is really what WHO data shows. The orange is really the out-of-pocket financing.
Which one is Nigeria?
Where is Nigeria?
You're right. Maybe 70%.
Middle right, yeah.
Wow, right? And then you can see the different composition. Anyway, this is for you to discuss and then say whether this is wrong or right. But again, just to make the point, it's not just how much countries are spending, but there are also important differences due to institutional factors, due to economic levels, in how resources are raised. So you'll see lower income countries are dependent, as you might expect, much more on external financing. Out-of-pocket spending tends to be high also in several countries. And so again, this is something to discuss and see whether or not this jives with your priors on the sources of health financing. So let me just close this by showing you this graph again. Again, the point here being, you want to share your sources of financing, Sarah? Canada?
So very little out of pocket, mostly government revenues.
Mostly general government revenues in Canada. So that's a high income country. Again, remember this slide that we had earlier about national income and how much you're spending. So now we want to add how you're raising that money as well. So I'm going to redo this. I'm going to take off the red line, that's a bit distracting. And here it's color coded depending on the largest source of financing for health spending. So it's showing you, like in Lebanon, general government revenues are larger than social health insurance. So the source of financing. Nigeria, it's red. Out-of-pocket spending is the largest source of financing. India is red, and so on and so forth. So here again, we're combining these two things that we talked about, how much and how raised and how pooled. And I'm just going to also introduce one, and we've done a lot of terminology today, but introducing one more point. if you sort of take averages, here I'm plotting that as countries become richer, health spending tends to go up from about $18 to $10,000. People have heard about the epidemiological transition. You've heard, what is the epidemiological transition again? As countries become more developed, switching the burden of disease, switching from communicable to non-communicable. You've heard about the demographic transition? What's the demographic transition? More elderly. If you can speak up, more elderly as you become richer, fertility rates go down, population aging. You know about the nutrition transition? As you get, let's do the richer part. As you get richer,
there will be nutrition status changes, but there will be malnutrition, in this case, not stunting.
From under to over nutrition, right? So there are these three sort of transitions that we talk about in health. So the health financing people said we don't want to be left behind, right? We also want our own health financing transition. So basically, I'm just going to summarize what we talked about all along. So there are empirical trends. This is just a trend. This is just on average. As countries become richer, health spending tends to go up. And this is showing you the share coming from external financing, and this is plotted on this side of the axis. So this is basically showing that when you're low income, it can be 35% on average can come from external sources, but as you become richer, the share, as you might expect, becomes lower. And then this is the out-of-pocket spending share. So in many low and lower middle income countries, on average, need not be the case for your specific country, the out-of-pocket spending tends to be the largest source of financing in many low-income and lower middle-income countries, as much as 40% of total health spending, and that tends to decline as more prepayment and pooling comes into the picture. These trends put together, you'll often hear the term, what is referred to as the health financing transition. Increase in the level of health spending and a significant change in how it is financed is put together is called the health financing transition. One point to note here, this looks very smooth and nice. Again, this is an average. It may not happen in your country. But this is what some people call the Bermuda Triangle. It's when external financing goes down, but it's not replaced by prepaid pool financing. So, out-of-pocket spending, there's a lag, usually because of the difficulties of a variety of reasons that I'll talk about a little bit later, as will Abdo, in trying to bring in prepaid pool sources of financing. So what looks like a very smooth process is also a lot of other things happening here. This is also the time when there's an epidemiological transition. Many countries try to establish or expand social health insurance unsuccessfully to try and get at more prepaid pool funds. They try to experiment with strategic purchasing. Often decentralization tends to occur at this period. So, this is not a smooth and easy process. And helping countries navigate their health financing transition so that they're making progress towards universal health coverage is a key challenge that Sarah will have a session on if you want to advertise it, Friday? Friday.
Parallel session.
Okay, so Nadeem, I hope I have another 10 minutes, right? People are not that hungry, and we don't want to encourage too much eating, no overnutrition. Just we just want to go back to the different health financing modalities and talk a little bit about the pros and cons of some. Some have already been discussed, but just to refresh and to begin the dialogue and to set the stage for Abdo's session. I also want you to this is a little bit difficult to understand, but it's also to make the point that how health is financed, either through out-of-pocket payments or community-based health insurance, general government revenues. Adrian, if you don't stop talking, I'm going to ask you to present this slide. Social health, it's really about who bears the financial risk, right? So if you're paying out-of-pocket, the patient is bearing, this is a crude way of putting it, the patient bears all the financial risk, it's the impoverishment and high catastrophic spending. As you move towards more prepayment and pooling, you're trying to make the risk go onto the agent, right? The agent, you're prepaying. So if spending ends up being higher than what was expected for that pool, I think somebody was making that point, the risk is now going to the agent in these things. And then, as we'll talk about later, in terms of purchasing models, it's about transferring some of that risk to providers. How you pay providers can also transfer the risk. So just think that in terms of thinking about health financing, it's also about how you set up and who bears the risk, the financial risk, and it can change as your systems evolve and different ways in which you experiment with systems. So this is financial risk of who bears the cost. So basically the last 10-15 minutes, I just wanted to get your sense. I think you've already talked about the pros and cons of external financing. So I think the pros are also important, right? External financing can, for some low-income countries, be very important, especially HIV/AIDS, immunization, global fund, earmarked funds. So, and also financing can come with much-needed technical assistance, and but there are some cons that you already mentioned. So, really, it's with regard to harmonization in terms of skewing and distorting service delivery. You can have sustainability challenges, as you pointed out earlier. Just to make the point that there are some countries in the world, like Mozambique, Micronesia, Liberia, where more than 50% of what is spent in the country is financed by external sources. And there are some other prominent examples. Community-based health insurance, I think some of the pros and cons were already pointed out, but the point here is it's a way to promote prepayment. Many countries, when they introduced social health insurance, in fact even Germany, right, initially had a form of community-based health insurance. Indonesia had that, so it's a stepping stone, so it can encourage prepayment, could play a role in mobilizing additional resources, provide some form of coverage rather than not having any. Usually the size of the community financing tends to be very low, and it's not sort of a very deep form of coverage. It's also to see what's on paper versus what's available. And two prominent examples are Rwanda and Ethiopia. And again, you have these notes with you for discussion for the rest of the week as you talk about different modalities of health financing. But just to give you a flavor of what are some of the pros and cons. Voluntary private insurance. What might be a pro or a con for voluntary private insurance? I think it's already been mentioned, voluntary, right? So you end up having people who will sign up if they're sick. So what's the term we call? Adverse selection. So so in some countries, I think there are at least 3 countries where they have compulsory private insurance. So does anybody know what those 3 countries are? Switzerland, it's no longer private, it's compulsory private. You have to buy private insurance. No, Germany's social health insurance. Netherlands has a form where the implementation is done, and also up those countries has a mandate now. It's still there, right? The mandate. Obamacare. US. Yeah, it has a mandate that you have to purchase voluntary private insurance. It may not be for long. Again, you can look at this at your leisure on what are the pros and cons, and can discuss further. Out-of-pocket spending. We've talked about the weaknesses. It's inequitable form of financing. It links access to your ability to pay. It's usually what is called regressive. Again, don't get afraid of the terminology. Regressive basically means that the poor are having to pay a higher share of their income. So it's like a regressive tax. It deters utilization. If you have to pay out of pocket, you're less likely to go and seek care, especially preventive care. In fact, in many low and lower middle income countries, you actually need to have negative out-of-pocket payments for prevention. What are negative out-of-pocket payments? It's like conditional cash transfer, especially because you want to encourage utilization. You want people to come in for preventive care so as not to create problems later. Many countries, I don't know if there are people in this room from Azerbaijan, or Armenia, Afghanistan, Yemen, more than 3/4 of total health spending is out-of-pocket in these countries. The other prominent examples, Nigeria, don't worry, I'm also there, I'm from India, one of the largest in the world, and Pakistan, the largest source of health financing, partly because public financing for health is very low in these countries. Lack of privatization, it's a lot of issues. India spends much more on importing arms than it does on healthcare. But there are political economy considerations that come into place as to how you're choosing to finance. And finally, a little bit on general government revenue financing. Here you're really financing out of general taxes. And let's look at the pros. Usually it's a very broad revenue base. You're able to pool risk, at least technically, for the entire population. easy to extend coverage to all, including those in the informal sector. You don't have to necessarily base it on wage-based taxes. You can collect consumption taxes or other forms of taxes. The financial burden of financing tends to get shared, can be progressive. Some weaknesses, potentially unstable, because it's related to also how the economy is. If you go into recession or if you're having slowdown in growth, revenues can be impacted by that. If you're in a country that has a sort of large poverty in informal sector, your ability to collect taxes, not just earmark taxes, but your ability to collect taxes more generally is also constrained. And of course, you can have the moral hazard problem. That's also true in other forms of prepayment and pooling. Some countries where more than 90% of total health spending is Tuvalu, Seychelles, Brunei. But there are many other prominent examples, and Sarah will be happy Canada is there. So Australia, Canada, Norway, Denmark, Sweden, Italy, Malaysia, New Zealand, largest source of financing is general government revenues. They don't have social health insurance. So this is sort of an example of another modality of financing healthcare. And I'll end this, I'm not going to go into social health insurance because I don't want to overshadow Abdo. But really one of the challenges of general government revenue financing, which will come up over and over again, I think, during the course of the week, it's really the best way to finance health for a variety of reasons for low and lower middle income countries. And one of the challenges we face is that of fiscal space, of finding additional government revenues. And when you're looking at immunization, you look at the number of children of 0 to 1 cohort, or if you're looking at HIV financing, you want to look at people who have HIV, TB, and so on. If you're looking for fiscal space, you've got to look at the size of the economy, because that's where your resources are going to come from. The national economy tends to be the biggest driver of health spending, especially of government revenue financing. So you start by looking at the size of the economy, and then look at the size of the government in the economy. So normally, macroeconomists tend to break up the economy in terms of what is the government share of resources, what is the household share, what is the share of firms, exports and imports. So here you're looking at the size of the government in the economy, and then you have health as a share of the government budget. This has to hold. There is no if, then, and else, right? This is an accounting identity. So this gives you what? If you take health share of public spending share of GDP, and the size of the economy, if you put these three things together, what do you get?
Good health.
You get good health? No, but from a financing part, what do you get? This is government spending. So this put together is public spending on health per capita. This has to hold, right? So this is one way of understanding what are some constraints and opportunities that you may face to do government revenue financing. Of course, you may be able to borrow, you may be able to have external financing here. You may be able to put cigarette taxes to get some revenues. You may be able to increase your general revenue to be able to influence this, but really this core equation has to hold. And of course, this is not the only thing that causes health outcomes. You have other determinants as well. But just to keep in mind that this is the tyranny of the mathematics of the general government revenue financing. And you take an example from Indonesia. Indonesia's GDP per capita is about 3,370. 17% of that is the size of the government. And then 7% goes to health. This is what is general government spending per capita in Indonesia. It's $40. You can already now see that if they want to increase this, the quantum of resources, you're going to have to either wait for this to go up, or this to go up, or this to go up. And also you understand the constraints that you might have. So this is the numbers for, I think this is 2015 or 2016. It's $40, but you can actually look back and see what happened in Indonesia in 2000. This is all corrected for inflation and things like that. So in 2000, Indonesia's GDP per capita was 1885. This was the size of the government spending in the economy, and this was health share of the government budget. So you can see this amounted to $11. So over 15 years, Indonesia's per capita public spending on health went up almost 4 times, from $11 per capita to $40. And you can see what caused that increase? A big reason for the increase came from economic growth, from increases in this. To some extent, there were also increases in priority given to health, very little contribution from the aggregate general revenues, the ability of the government to increase its size in the economy. So I think, is it 1:10? What is the time? 1:15. So I think we can stop here. And this is sort of, the overall, I think I have one slide that summarizes the key messages that you want to take away. You want to take away an understanding of universal health coverage, and where does health financing fit into universal health coverage? Where is it? It's intrinsic to the definition and conceptualization of health financing, to recognize how it is recommended that progress towards universal health coverage be measured, including the financial protection, so that you're not having to pay too much out of pocket. The health financing was one of several control knobs. We're going to talk about several others. And I don't want to necessarily point this out, but Nadeem will like this, that health financing cannot be disconnected from other control knobs. I think that's another key point. You can't only talk about health financing in isolation. It has to work with some of the other control knobs as well. And we looked at the definition of what really health financing is. It's not just about how much resources you have, but how they're raised, how their prepayment and pooling occurs, how benefits are defined as to what can be financed by prepaid pool sources of financing, and how they're allocated to help countries make progress. There are different health financing modalities. We talked about the 6 big ones. They all differ in how resources are raised, pooled, and how health services are purchased. And really, for universal health coverage, it's reducing the dependence on out-of-pocket payments, especially for the poor and vulnerable, and increasing the share of public financing and allocating it in ways that does so. That means allocating it in ways that is co-poor is key for making progress towards universal health coverage. So I think we'll stop here. Is Nadeem, is lunch provided as part of the lecture? No? And this is sort of the second part after lunch. Abdo will go do a deeper dive into social health insurance, one of the health financing modalities that we talked about. So thanks very much. When do they come back?
2:30.
Back at
2:30. Since poor Ajay had to rush through his session, we thought it would be good to take the first few minutes to see if you have some questions for Ajay. He's here. He's happy to answer them. So before we jump straight into social health insurance for the 21st century, any quick feedback, reactions, questions from Ajay's session, which covered an amazing amount of ground. It covered a lot of information, and it was important to cover that information. But, yes, ma'am.
So, Ajay, I'm sorry, please forgive my ignorance, but I did want to know, what is the relationship between public financial management and health financing? Where does it intersect?
Good question.
Good question. So the best way to answer it is, public financial management is really referring to how you make budgets and how you sort of implement them and how money flows through the system. So typically, it doesn't have to be the case, but typically, and maybe Sarah, you want to talk a little bit about that. It's considered to be part of efficiency in terms of if money doesn't flow the way it's intended to, budgeting is not geared towards dealing with the biggest disease burden problems and things like that. So PFM is sort of a subset many times. In fact, one of the SDGs is about PFM, and the indicator is to what extent of your budget actually got disbursed. Or something like that. So, they look at whether or not you're able to plan for and execute expenditures. And I think Sarah, in her session, will touch on PFM challenges, especially as they relate to budgeting.
Just another comment. I think also Ajay would probably agree that it's also, the PFM is also related to prioritization, because if you're using resources well, then you're better able to make a case for additional resources, but also because budgeting and planning, particularly as we're thinking about priority programs and development assistance, often the budgeting and planning for those programs may be separate from the broader health sector. So integrating those PFM systems will be particularly important. But great question. I think we're all kind of struggling with that. I think even as we're organizing various flagship courses, we think, well, where does PFM fit? Because it fits everywhere. But it's also obviously a very important part of health financing. Thanks.
Actually, we have so-called organizational control now, and it's not just organization of service deliveries. It's also organization of how you govern. It's also how you manage institutions, how you allocate the budget. So it's really different from financing for health, but it's underlining cause of many problems or successes. Just like you would say, where does information technology fit? Is it service delivery? Is it financing? Is it organization? Is it? It's basically enabler of many things. So the health lives in certain environment, which is how do you allocate your resources, how do you manage them, what accounting procedures you have, and so on and so on. So you can fit it anywhere. We are hoping to fit it under organization control now, a little bit more explicit, but it's really struggle because we're also thinking how do you fit information technology, for example, because it fits everywhere.
Very good. Second question.
The second question is in relation of out-of-pocket payment and private. Could you explain? First.
Go ahead.
Yes. Yeah. Could you please explain the relations or correlations between out-of-pocket payment and private expenditure for health? Thanks.
Another very good question. In fact, the way one classifies health spending has changed in the system of health accounts. So earlier on there used to be public and private, but now they differentiate between whether or not it's compulsory or voluntary, whether it's out of pocket versus not out of pocket, and whether it's external or domestic. So typically out of pocket is considered a private source of financing, but you can have other private sources of financing as well. You can, for instance, voluntary private insurance is a private source of financing. As soon as the voluntary part becomes compulsory, based on the national accounts, if you have a compulsion to have to buy private insurance, that becomes public. So, but then you also have in some countries firms that provide care. So for instance, in Sri Lanka and India, a lot of the tea plantations, in the private companies, they provide full care for their employees. So that's also private financing. So normally, out-of-pocket is part of private, and usually it's the largest part of private, but you can have other sources such as private insurance, private firms, providing care for their own employees, and so on and so forth.
A couple more, one here.
Thank you. I know we're not really getting into strategies for domestic resource mobilization, but I was hoping you could comment. I was hoping you could comment briefly, just specifically on excise taxes, because you did mention the sin tax in the Philippines. Just what are your opinions on it? When are the conditions where excise tax might be introduced or might be something to think about?
Right. So there are two parts to this answer. So one is excise tax or taxes on unhealthy consumption, right? For instance, for tobacco consumption or alcohol or sugary products. So that can be implemented not just as a way to raise revenues, but really from a health point of view to try and reduce the consumption. In the Philippines, they actually introduced alcohol and tobacco taxation that was then used to pay the premiums for the poor. Experience has shown that these sorts of taxes, they're marginal. So if you find me one health system that is financed out of cigarette taxes, I'll personally give you the Nobel Prize. So they tend to be marginal, but they can be very important at the margin, right? I mean, in some cases, that they can be very important from a health point of view, but we have to keep it in context, right? In many ways, they're very similar to social health insurance contributions in terms of the magnitude of resources that you can gain. Now, the other point is that you may want to earmark consumption taxes otherwise. Is there anybody from Ghana here in the room? So in Ghana, they
1%, be careful.
earmarked VAT, right? So that's got nothing to do with cigarettes or things, but it's another form. Instead of earmarking payroll taxes, income taxes, they are earmarking consumption taxes to try and get around some of the issues that Abdo is actually going to talk about. So I don't know if you want to share. 2.5% of the VAT in Ghana goes directly to finance the social health insurance program. And also this is a discussion that's happening in France and other countries as well, where they're moving away from income taxes to consumption, wealth, property taxes as a way to raise resources and augment some of the challenges that actually Abdo is going to talk about.
Any other questions for Ajay on the first lecture? Can you give him your mic?
Mine is just a comment, actually.
We're going to call this table the troublemaking table.
Welcome, positive trouble.
Yeah.
But actually, it's a source of revenue that I noticed in some countries, particularly a country like Sudan, where they have what they call the zakat tax, which is a major source of revenue,
right,
which can easily be accessed and pulled into the state for social health insurance. And truly, in such countries where you have large Muslim population, zakat can be as much, so huge, that really can actually be pulled back and finance the entire system. Probably it's an opportunity, to begin to look and see how many countries can actually utilize the zakat tax.
Very good. Thank you. Any other comments, questions? Thanks, Ajay.